everyone. As you get signed in, you will see a survey on your screen. If you could take a second to fill it out, that'd be great. You can also drop into the chat where you're calling in from today. We'll get started in just a few minutes to allow for a few more people to get signed in. But as we wait, I would like to introduce myself. My name is Madison Burnett, and I'm a BCBA. I lead our professional development program, and I'll be supporting throughout the webinar today. In addition to that role, I work alongside other BCBAs on our clinician-led recruitment team, and I support in the effort of recruiting quality professionals to join our team. If you are interested in joining MPG, please indicate so in the post-webinar survey at the end of this webinar, or you can email careers@manhattanpsychologygroup.com. All right, I see we have a lot of returning attendees, about 75%, and then 25 are new. So welcome everybody. We are thrilled to have you all. On the next page, you'll see a little bit about Manhattan Psychology Group. We were established in 2011, and we've continued to grow our team consisting of skilled adult and child psychologists, neuropsychologists, behavior analysts, special educators, and licensed social workers. As a team, we're committed to wraparound care, which includes our wide range of services from mental health and testing to ABA and educational services. This holistic approach allows us to address various needs and challenges with compassion and care. We provide services to clients out of our Upper West Side and Long Island City offices, in home, school, and clinic-based settings, as well as through telehealth. Our team is committed to serving individuals, couples, and families of all ages in diverse settings. We're also pleased to offer these monthly webinars for parents and professionals, where we will continue to learn and foster meaningful connections. Our vision at MPG is to create a future where individuals and their families feel supported, connected, and empowered. And our mission is to provide multidisciplinary integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. Next are some housekeeping information about CEUs. For those seeking CEUs for this presentation, you will need to collect the code words stated and complete the post-webinar quiz and survey. We will post the codes on the screen and verbally say them, and once we say them, we will move on and not be able to come back. We will send out a post-webinar quiz in the last 10 minutes of the presentation for you to get your CEU. As of January 1st, we have started charging a nominal fee for the continuing education certificate. This webinar is still free to attend, but will be $3.75 to obtain a CEU certificate. Any polls during this webinar are not required, but they are encouraged. We will be leaving the chat open, excuse me. We'll be leaving the chat open, but please post any questions you have in the Q&A so we can make sure that they are seen. Now, I would love to introduce our speaker today. Nissa Van Etten, doctoral level behavior analyst, licensed behavior analyst, and has also received her PhD. She has over 20 years of experience working with individuals with autism in a variety of different settings. Nissa has held a variety of clinical roles, working in clinic-based and educational settings, and is passionate about clinician training, compassionate care, and cultural humility in behavior analytic practice. And now, without further ado, I will hand it over to Nissa.
All right. Good morning, everyone, and thank you for joining us. I'm really excited about today's topic and discussion. We've got a long 90 minutes ahead of us, and I get really excited about it. So Madison's going to remind me in regards to time and keep me on track and make sure that I don't kind of go off the wayside. I always like to jump in, show you the learning objectives that I hope you walk away with when you participate in this discussion today. And I say discussion because I do want to ensure that we use the chat. There's some active student responding or active learner responding components of this that I'm going to launch, just so we can get to know each other, as well as kind of your culture, your subculture, and where you're joining us from. So first, we're going to look at identifying at least 3 strategies that can be adapted to enhance cultural responsiveness in your behavior analytic practice. We're going to look at self-assessment tools and simulation-based training. We're going to really understand how you can walk away from today's 90 minutes with something you can apply to your clinical practice. I'm going to describe the key components of culturally responsive care and some tools to support supervision practices. So not just your clinical practice, but your experience as you supervise behavior technicians, registered behavior technicians, and then aspiring behavior analysts or those supervisees or individuals receiving supervision hours towards becoming a BCBA. And then in the end of this, I would love if you could walk away by listing 3 ways to incorporate cultural considerations into behavior analytic practice. We're going to look at that assessment tool in culturally responsive care, as well as the study of culturally responsive interventions and their effectiveness. So those are some of my objectives for you as you step away from this webinar. I've hosted this webinar a few times in multiple settings. So sometimes at the university level, sometimes with other behavior analysts. We're going to review topics on culturally responsive care. And as we consider that topic, as well as the state of our nation, you may experience some of the feelings presented on this emotion wheel. Just like the clients we serve, some of these emotions may just pass right through you. You may not be aware they're happening, and they could come as a surprise or shock. One thing I like to advocate during this topic is to allow yourself to experience these feelings and sit with them. Another thing I'd love for you to do, something that's starting to move into clinical practice or training for behavior analysts, is to note these or jot them down so that you can go back later after this webinar to understand why these emotions or feelings might have come up as we talked about these things. So a little bit of background about myself. My name is Nissa Van Etten, and I am of Thai descent. So I am a first-generation Thai American, and that is one of my subcultures. I was also born and raised in Southern California, so that is my region of origin. That really did influence my language, my jargon, how I see the world. And I am a minority woman, which is another large influence into how I see the world and how I show up into the care I provide. So as we launch in, I do want to pause and give you all a moment to share your culture or subculture. If you are on your phone or on a computer, if you could just go to menti.com and enter the code up top. This will populate it'll be a nice word cloud to show who's really present with us today. Menti.com, and the code is 6704-9143. And let's see if we can get some respondents in there. As you do that, I'm going to keep discussing some of that. So one of the important components of understanding your culture and subculture, we'll talk about it in a little bit, will really allow us to show up for the clients that we serve, show up for the individuals that receive our care. And I see that we've got someone from the Southern US. And as we work with different individuals and show up into their homes, show up to provide practice, and then those that we supervise, being aware of our culture, our subculture, and how we communicate is really important into providing that information for our clients, as well as understanding who they are and what they bring and what is required to serve them properly. So this is a fun little word cloud. We can see where many of you are joining us from. We've got a lot from the East Coast, New Jersey, New York, I'm seeing that, Long Island. Welcome today to this webinar, and I'm excited to be able to have your live participation and be able to see everyone that is joining us today. I'll let that run for a few more seconds here, and we'll jump right in. Other things that contribute to our culture and subculture, many of us on this webinar, we're behavior analysts or we're students of behavior analysis. And that contributes to the jargon that we use, the language that we understand, and those components of care that we provide. So that's something to consider as we talk about this topic. Another thing that comes up when we think about who we are in clinical practice are the multiple contingencies that contribute to the way that we show up. The emails, the schedules, attending a CEU or a webinar training, being able to manage multiple contingencies are also contributing factors to how we show up to care. So in that, I've got one more active student responding component. Let me click that button for you. Again, back to menti.com. Have you received training in DEI, cultural responsiveness, or cultural humility? And I love to see this data come up. So I started giving this training about 3-4 years ago. I've updated it as literature has come out, but those in the blue bar, the yes respondents were really low early on. We saw that training in DEI, cultural responsiveness, or cultural humility was really low in behavior analytic practice, especially in the last decade. We know now that it is becoming a priority. We know that the BACB is also going to require that CEU for cultural responsiveness, and we'll talk about that in a couple of slides. All right, so 50 people have received this training. This is fantastic. Okay, thank you for joining and participating. Let's jump right into that practitioner and client relationship. This is a large component. We're going to do a little bit of a backwalk into bringing in compassion, client practitioner relationships, and then we're going to move that into culturally responsive care. The image that you see on your screen, this is an oil painting by Sir Luke Fildus, and this was painted in 1891. Some of us have seen this image. You may have seen it in your doctor's office. You may have seen it if you've looked in any sort of doctoral training program or nurse practitioner training. What we have here on the left-hand side is an individual, gentleman in a maroon coat. That's the doctor, and he's leaning over a patient. You can see a little girl laying on two chairs, so I would imagine this is an in-home setting. In the background, kind of back here, we see who we might assume to be the dad, and then a mom with her head down, clutching her hands. This image is representative in training for many practitioners currently in modern healthcare because it brings those individuals back to their why. And what we know about this is that when you have a doctor who demonstrates countenance and care in the way that this doctor is demonstrating it, it shows that this individual is compassionate, that he cares about this child in a way that he's trying to consider what is it that's impacting her, what is the meaningful care to provide. And as he's going in home, you can see that the parents are under distress. I've got this painting in my office, and I know that whenever I'm distressed, whenever I'm working with parents that are going through grief or struggles, I know that sometimes this brings me back to my why, right? That meaningful care means caring about the patient or the client, the individual who's receiving those ABA services, and allows us to focus on the patient and physician relationship at the core of building a strong therapeutic relationship. What we see in this image, this might be our modern day healthcare or modern day interaction with a doctor, right? So this is similar to what we saw in the last one, but that's what we see today. We see a doctor sitting with her patient and his mom. You can see she's oriented, her body is facing both mom and child. She's sharing information and discussing treatment recommendations. And what we can do is we can consider how we can learn from these allied health professions, and we'll talk about the definition of that in the next few slides, and how we can consider their countenance, their training in their why, to understand how to provide care that is compassionate, culturally responsive, and really ensures that we're looking at that individual. So we know that culture plays an integral role in how we provide strong therapeutic relationships with the families that we serve. If we as behavior analysts are aware of the family's unique backgrounds and culture and how to build rapport with these families, we can ensure that we communicate well with them, interact with those families, and support them by developing rapport and trust. These are essential not only during the first meeting with families, especially at that first assessment intake meeting, but ongoing meetings as well. I'm going to pause here and share the first code word for your CEU. Don't forget to jot that down. Your first code word is compassion. All right, we're moving on from the code word. We're going to talk about culture. We know that there are so many ways that we can define culture. You can do a quick Google search. You can look into a dictionary. You can look at scholarly research, as well as some of the literature in regards to culture in behavior analytic practice. And that's what's really exciting, is that culture is being discussed in behavior analytic practice. I will say, and you can find this at the end of the webinar today, there are numerous publications recently in behavior analysis that talk about culture, talk about the need for more training in culture, and really allow us to understand how culture impacts clinical services in ABA. But let's go back to B.F. Skinner's definition of culture and how we as behavior analysts might evaluate that term. Dependent on what members of a particular community that share cultural variables defined as conforming behaviors. And that was Skinner in 1953. So what he indicated there was that what is selected as a cultural variable is dependent on the members of that community. So when we first started talking about the subgroups or the subcultures we belong to, or cultures, we are all shaped by the culture that we engage and participate in. So those engagements with colleagues of behavior analysis, if we are students of behavior analysis, we're using the jargon frequently and we're being reinforced for using that jargon. Depending on where you are regionally. So I know a lot of you in the responses indicated that you're on the East Coast. That's also a component of your culture, and the culture of origin is a component of your culture. Culture is also defined as selected and reinforced by the community one participates in, which can include your social activities and engagement, your verbal behavior, your socially acceptable behavior, and your parenting styles. And then lastly, it's shaped and reinforced by learning history and behaviors of the members of that community. So one, culture is very impactful on us as clinicians, but it's also very impactful on those clients that we serve as well as their families. And it's incumbent upon us as practitioners to understand those cultures of the families that we serve. Last definition of culture by B.F. Skinner, and this was in 1971 and 1988. He said that clinical relevance of a given behavior, so those behaviors that we may select as practitioners, and its functional relationship it has a functional relationship with immediate environmental events. These are influenced by the client's culture and their social environment. So something that I started to bring into my practice as a result of really digging into the history of culture and how Skinner defined it was to start to ask families that I serve about their subculture and their culture, how they participated in social activities, how they communicated with others, and that allowed me to understand and evaluate some of the treatment goals and treatment efficacy for the clients that I was serving. Okay, the ethics code has added a new section regarding cultural responsiveness and diversity. I'm not going to read this all the way, but I think that many of us have seen it. Please take your time and read through it. It's really important to note that there are numerous training options related to this topic, right? We know that there are prominent behavior analysts such as Patricia Wright, Matthew Broadhead, and the late Dr. Elizabeth Hughes Fong, who have written papers on how to consider and develop these skills related to cultural responsiveness and diversity. And then I know that a number of professionals and well-known practitioners in our field are beginning to grapple with this topic and ways to provide CEUs on culturally responsive care and diversity as it relates to client care as well as supervision, similar to the one that you're attending today. Okay, why is there a need for cultural awareness? One, the US Census Bureau predicts that by 2044, the US will be a majority minority nation or a majority minority population. And Fong and Tanaka in 2013 indicated that there will be no group with a majority in the population, making cultural diversity training critical for behavior analysts. I don't know if anyone knew Dr. Elizabeth Hughes Fong. She did pass, unfortunately, 1 year ago. And she was a large contributor to cultural diversity and cultural responsive care in behavior analytic practice. One thing that I like to bring up is you can see on this reference here that this paper was written in 2013. So over a decade ago, they were making the case that we should consider culturally responsive care in our practice, that when we walk into a home or a school or serve a client, these individuals come from a large number of backgrounds, and it's important to be aware of their background as well as our own as we serve these individuals. It's wonderful that this is becoming a priority today, but you can look back into the literature. There are a number of podcasts available where Dr. Elizabeth Hughes Fong talks about the requirement for culturally responsive care and cultural awareness. So how can we view this from a contextualist view? So Anthony Biglin talks about the contextualist perspective. And what we see here in this just little nestled image, we've got the individual in the center, we've got the family, and then we've got society, right? When we look at the role of group level phenomena, so that group level being at the societal level, the social norms and values impact the individual via the family. So in understanding the way that our families that we serve show up, what their social values are, what their norms are, that allows us to identify treatment targets that are going to be significant to that individual who receives our care. That's the beneficent of our care. An example here would be considering institutional level contingencies that impact that individual via social contingencies. So for example, if a family finds it important for approval from peers, these values and beliefs are aligned with that behavior and ensuring that peer relationships are significant, and that's going to impact your client. So if you've got a family that's participating, I know I live in Austin, Texas, that attends church and participates in church, that might be a significant area where socially significant goals would support the client so the family can participate and go to church and participate with their social group. That's one way to really look at it from a contextualist view. Okay, we're going to turn to allied health professions. Feel free to drop into the chat if you've heard or researched anything about allied health professions. It's a nice segue to go back into compassionate care, right? I laid a little bit of a foundation as to why it's super important to think about culturally responsive care. We're going to talk about that for a majority of our discussion today, but in doing so, we know that as behavior analysts, we're new science. And the way that we've learned a lot of what we do moving into medical necessity is by turning to our counterparts in allied health professions. These are those professions that operate in a manner similar to behavior analysts. These are helping professions. These professionals seek to reduce the burden on patients and improve their quality of life as well as their health. Some of these include nurses, dentists, palliative care physicians, and then marriage and family therapists and social workers. The research in healthcare and allied health professions indicates that therapeutic relationships have become key indicators to successful patient outcomes. So Hojat and colleagues in 2011, they published a paper in regards to patient outcomes when it came to taking their medicine for diabetes. And they found that patients that really worked well with their practitioner, that liked their practitioner, they were more likely to adhere to recommendations than those that didn't have a strong therapeutic relationship with their practitioner. Hojat is the author of the Jefferson Scale of Empathy. It is a free tool if you are interested in just evaluating yourself or even your supervisees on empathy. It's an easy to administer kind of scoring rubric, and then you get your kind of your scale of empathy, and it indicates kind of where you fall on that range. And what the papers published by Hojat indicated that most of us in helping professions will fall kind of in that 100 range, indicating that we are empathetic and we select the field that we work in due to our empathy that's already embedded in who we are. However, there will be individuals in our field that might not be in that 100 range, and training might support developing some of those empathy skills and compassion skills as well. Okay, we also know that Bonvicini and colleagues in 2009, they conducted a study on nurses, and they found that there's a strong body of evidence in allied health professions that suggest these types of skills, like I indicated, compassionate care skills can be taught. Bonvicini developed a really nice training for nurses on how to develop these empathy skills and then display them when working with patients. So this leads us to compassionate care. Feel free to drop into the chat if you have heard about compassionate care or taking a training on compassionate care. We know that this is a buzzword. It's a really interesting hot topic currently in our field. I see a lot of individuals are saying, yes, I've taken trainings on compassionate care. They've become really important into the work we do. And I think I've seen a number of discussions going back and forth on, compassion is something we already do. We don't have to name it. However, having a name allows us to indicate which behaviors are aligned with compassion. And thank you so much for dropping into the chat. It looks like a large majority of you have engaged in compassionate care training. There are also numerous papers and continuing education opportunities for behavior analysts to begin to consider these topics as they relate to our practice if you have not read any of the research or taken any training. But if you have not, let's define compassion. What does it mean, and how is it related to the work that we do? Compassion, on the left-hand side, it is a focus on the individual, emotional, attitudinal, and cognitive factors related to care. That was from Crawford and colleagues in 2014. Again, we're looking at the allied health professions. A lot of these terms will be used for nurses, palliative care, dentists, and social workers. Compassion is also an altruistic role of the responder in which they would like to action the amelioration of pain. So they want to remove the pain that the patient or their family might be feeling, especially when it comes to healthcare. What compassionate care is defined as an amalgamation of various terms defined in the literature for therapeutic alliance, another nice synonym for rapport building, relationship building in health professions. And then it is behaviors toward the client and parent that provide emotional relief during interactions, conversations, and moments of duress. And Berg and colleagues looked at that in 2011. They really looked at compassionate care by providing feedback statements, ensuring that we were providing the compassion, the empathy, repeating emotions to the families being served. So what do we see in allied health professions? That therapeutic relationships are important, that building rapport with the client and their caregiver is significant to outcomes and treatment, that compassionate care skills can be taught. If you have someone that might not be compassionate in nature, maybe they've taken the Jefferson Scale of Empathy, or you are supervising them and identify that there's some kind of compassion, empathy skills missing, that you can teach these skills. And that empathy, active listening, and compassion support a patient-provider relationship, right? These are indicated in the allied health professions research as key indicators to successful patient outcomes for treatment adherence, attending treatment recommendations, and then making sure that these positive relationships support caregiver implementation of recommendations. And that's something that I know as a field that we grapple with when we provide parent training. So now we're going to turn to compassionate care in our field in behavior analytic practice. And we're going to look at some of the literature that's been published recently. I know many of you had indicated that you received training in compassionate care. Well, the seminal paper that was published by Taylor and colleagues in 2019 looked at compassionate care directly related to the delivery of services from BCBAs. And what they did was they surveyed parents of children with autism. They did this through a public Yahoo group, so we can see kind of how back in time this was. I don't know how many Yahoo groups exist today, but this was sent to an undisclosed amount of recipients. So a large number of parents, these individuals were tied to a number of organizations who just sent a link and said, hey, parents, if you are receiving ABA services, we would love your anonymous feedback in relation to your relationship building with the BCBAs that serve you. Again, we had an undisclosed amount of recipients, but only 95 surveys were returned. So what you'll see in this paper are 95 responses to the survey, which is not a large N, but it's enough to really pull the information from and consider how we bring compassion into our practice. The survey included items that represented areas that contribute to a therapeutic relationship or could harm the therapeutic relationship. And caregivers were directed to select their level of agreement with the statements that were presented. There are 3 areas in which Taylor and colleagues evaluated parents. The first one was listening and collaboration. They asked these parents to indicate how well does your BCBA demonstrate these skills. So you've got on the top left, compromising, clarifying roles, collaborating and communicating, modifying programs based on concern, socially significant targets, including the whole family, considering the caregiver's perspective, actively listening, protecting confidentiality, and then confirming caregiver agreement. The areas in which behavior analysts did well, I think we would all be very surprised if this was not accurate, but protecting confidentiality. That was almost 100% where parents indicated every time I worked with the BCBA, they remained protectant of the confidentiality of my client and other clients they may have served. They also indicated that this was not that important to them. Areas in which behavior analysts could improve as a result of this paper and survey were compromising, clarifying roles, and including the whole family. Again, of those 95 parents, many of the families really wanted to see that the BCBA clarified roles. So what is my role as a behavior analyst in your care? Compromising on some of the goals and objectives to provide in implementation, and then ensuring that the whole family was included. So that could have been grandparents, aunts and uncles, or siblings in the care. Next, we turn to empathy and compassion. They looked at understanding, so understanding the family and their experience as a family. They included reassurance, displaying an understanding of when things were difficult for the family, acknowledging mistakes, regular check-ins, cares about the parent's capacity to parent, considering the caregiver perspective, if the BCBA was genuinely friendly and warm, or friendly, genuine, and warm, if the BCBA cared about the child and progress of the child, and then celebrating accomplishments. In this area, behavior analysts were really great at celebrating accomplishments, as well as caring about the child and the progress of the child. So that was one area in which our respondents indicated that BCBAs were doing well. Areas that we could improve included these 2 areas here: understanding the perspective of the parent and caring about the capacity to parent for those parents. Really understanding kind of their role in treatment, their role in their child's life, and just providing that level of empathy and understanding, that perspective taking that's really important to care. And this last one, this was where areas in which the behaviors of behavior analysts contribute to problems in the therapeutic relationship. So here they asked parents about the BCBA having their own agenda, underestimating the child's ability, focus on challenging behavior, does not communicate consistently, has an authoritarian demeanor, appears too busy and distracted, uses technical jargon, interrupts versus active listening, does not discuss what is important to the caregiver, and focuses on child deficits. As a result of this survey, this is the area in which behavior analysts could improve the most. parents indicated that many of the BCBAs related to the survey came in as experts, so they might have had their own agenda, they might have had an authoritarian demeanor, and then many of them used heavy technical jargon that was not easily understood by the families. So again, going back to the beginning of our talk, talking about understanding our families, their culture, where they come from, and then understanding our culture and subculture and our use of technical jargon, ways in which we can translate that, right? I work with a number of supervisees that I would call apprentices, and we do a lot of translation of, the mands, the tacts, and the verbal operants, and practice how we might break that down for a family to understand where we might not be using technical jargon heavily. Okay, here is as a result of the survey from Taylor and colleagues, I went ahead and worked on training compassionate care skills to early professional behavior analysts. And what was developed from that training were some key indicators, some key behaviors that we might want to consider training our aspiring behavior analysts and early professionals in developing and managing. So what you have on your screen is a checklist, some things to look for when you're doing some simulation, some practice with your staff. One is positive social interactions, right? That's a key component that we've seen from allied health professions that say this helps build rapport with the families that we serve. On the right, some of the behaviors you'll look for: do they smile? Do they acknowledge the caregiver? Do they make positive comments about the caregiver and the client? Do they engage in eye contact? And then one of the things parents indicated, they do like to be greeted by name. And then that aligns with some of the quality assurance checklists that have been published recently in quality assurance and quality ABA. Next, empathy. So we have some of those key behaviors that are related to empathy and how we might demonstrate them, as well as evaluate them in those that we supervise. We've got compassion there, so providing acknowledgement and making supportive comments, demonstrating an understanding of caregiver experiences, using a calm and mild tone, going all the way back to the doctor and his countenance and how he was hunched over the little girl. That's an area to consider. Are we demonstrating that with our face when we're talking to families? And then asking clarifying questions. If we don't want to assume that we understand how a family is feeling, so we might say, did I understand you correctly, or did I get that right? Collaboration is another component that we can provide these very key behavioral indicators, things that we can check off when we're evaluating interactions. And then the last one, which we can expand upon, we'll talk about during today's training, cultural awareness, right? These are components where we ask about the caregiver's family practices. We demonstrate an understanding of differences by offering alternative treatment methods, considering their cultural differences. And then going back to aligning with treatment objectives, do we offer alternative treatment goals based on the family's culture? I talked a little bit about that in my experience here living in Austin, Texas, and some of the families I've served who really prioritize attending church and having their child attend with them. Okay, so what do we know about core skills of compassionate care? We know that positive social interactions are a very core skill of compassionate care. Empathy is a key component, collaboration, and then demonstrating compassion. Okay, we're moving right back into culturally responsive care. And in doing that, I want to talk a little bit about the BACB demographic data. They were released a couple of years ago. You can see on my screen 53.6% of RBTs, BCABAs, and BCBAs, as well as BCBA-Ds, are white. We know that a majority of practitioners in our field do identify with that. 85.22% are female. So we've got a large percentage of our field that are perhaps female and white. And we know that clients and students receiving behavior analytics services do not make up or match the large percentage of clinicians available to serve them. So we know that sometimes the matching of clinicians to clients isn't going to be the same, and we aren't going to have individuals with the same background. So participating in trainings like this, being aware of your own culture, where you come from, and the family's culture is incumbent upon us to really ensure that we are considerate of the families we serve. Some more data points here: 21.6.9% or 69% are Hispanic or Latinx. And then again, of the individuals on the demographic data, 72% work with autistics or individuals with autism. We know that from the Fong and Tanaka paper in 2013 and the CDC's report that the United States will become a majority minority nation in the coming 20 years. So this training is important. The requirement to understand culture is important. And what does that mean? It means that research indicates that most behavior analysts have not received training or support in how to work with clients of diverse backgrounds. And again, this was Belier and colleagues in 2019. So that was about 5 years ago. The respondents here participating today, a percentage of you have received training. So that's fantastic to see that some of the data are a little outdated, that we are starting to see more individuals participate in trainings like this to ensure that they're aware of how to interact with families and clients of different backgrounds. We also know that organizations should consider and provide training in culturally responsive care, working with diverse populations and self-assessment on bias. We're going to talk about bias at the end of today's webinar, as well as literature on how to administer and conduct self-assessment training on bias, as well as where to find some of that literature. Okay, we are on code word number 2. Your code word number 2 is the word nurse. Let me give you a few seconds here. And then I did see in the chat, there was a question regarding the respondents of the survey and kind of how that might be self-selected, right? Some of the families that maybe open up the survey and participate and respond might want to provide feedback on that, and it's important to them. And maybe the relationship was really good, or it might have been not so great, and they wanted to kind of highlight that. And that's completely accurate. I think that it would be great, and I know Dr. Bridget Taylor, she was on my committee when I worked on my dissertation. She said it would be great now to have different organizations evaluate the families that receive care in a very similar fashion, just open-ended, not related to, very anonymous, to say, are you receiving the care that we believe you should be receiving? That's compassionate in nature. Do you have a great relationship with your BCBA? And I wouldn't say making it a requirement, but providing that information so that the families that select it aren't self-selecting feedback. Okay, culturally responsive care in allied health professions. We talked about who these individuals are and what these professions are earlier, but just a quick snapshot of the literature we're going to go into. We're going to do a little bit of a lit review, which will be fun to see kind of where training on cultural responsiveness has been for some of these professions. The first one is integrating diversity, equity, and inclusion training into graduate nursing curriculum. And this was written by Smith and colleagues in 2019. In this paper, they look at how to incorporate DEI training into graduate nursing curriculum. This became a core requirement for students of the program, and they participated in a 4-course DEI workshop series based on cultural awareness, unconscious bias, safe zone training, and bystander intervention. The paper is wonderful. It breaks down what those courses covered, how these nurses were trained, as well as the impact and implications to the families that were served as a result of the training. The significance of this paper indicated that DEI training is as important as patient populations are growing more diverse. So we are seeing the same alignment in our own profession. In this training and in this paper, they talk about a review of cultural humility, implicit bias, LGBTQ issues, and strategies for discrimination situations. So you can also see in this paper that they talk about different ways to mitigate discrimination situations. There's some practice, some active responding, and some considerations for those that read the paper. And some of the implications indicate faculty trained before students. So one, if you're going to be requiring DEI training in a course curriculum if we think about our field, the verified course sequence or the model that's moving forward for graduate training, staff training should occur first. So faculty training should occur before student training. I think that's something that we know as a science ourselves. They also indicated that requiring DEI training and incorporating role play and feedback would be significant. It's important to ensure that DEI training and role playing are a component of it. So just not didactic training, attending webinars, but actually role playing those scenarios with individuals that are receiving supervision hours. And then explore best practices of curriculum versus standalone courses. So what they did was they talked a little bit about taking trainings like today. It's a webinar on diversity, how you might incorporate it into your practice. And if there's a difference between taking a training like this or incorporating a required level of culturally responsive care in coursework and what the outcomes might be. So this is an area for future research. It's an area to explore more and take what we've learned in graduate nursing training and see if we can bring that into behavior analytic practice. Rosal and colleagues in 2009 talked about ethnocultural empathy among students in healthcare education. They evaluated levels of basic empathy and ethnocultural empathy among students in healthcare programs. So they looked at students in psychology, social work, and nursing. They compared scores on empathy at pre and post semester instruction. And they also had students administer a self-assessment on attitudes and beliefs of diverse populations. Some of the results indicated that psychology students demonstrated higher general and ethnocultural empathy. So that pre and post indicated those students in psychology really did demonstrate higher levels of this type of empathy. They also found that there were disparities across programs, which were evident at the onset of courses, but decreased as students became more aware of the skills. So again, looking at that pre-semester instruction, there were large numbers of disparities amongst these different students, psychology, nursing, and social work. And then as these students participated in training, they became closer and closer in regards to their engagement in ethnocultural empathy. And then they also found that there was a gender correlation with empathy scores, which is really interesting and something that I would love to see in future research here in behavior analysis. Some future directions they recommended: longitudinal studies tracking empathy over time, diverse assessment processes for students in related fields, and then evaluating factors that promote or hinder the development of empathy in healthcare. Returning to the Institute of Medicine in 2003, here they looked at unequal treatment, confronting racial and ethnic disparities in healthcare. This paper looked at examining potential sources of disparity in healthcare based on the clinical encounter. They surveyed a number of individuals who interacted with healthcare providers and just did a quick survey as these individuals were being released from care. They also found that time pressure and limited background information may promote reliance on stereotypes. So many nurses who were working with the patients in these surveys indicated or demonstrated that the pressure of time, taking notes, being able to spend time with their patients would limit their kind of equality in treatment or care, which would promote their reliance on stereotypes or their previously conceived beliefs about a group or subgroup. They also indicated that bias can influence clinical decision-making, even if it's unintentional. We're going to talk about that as well, right? That the bias that we carry around that we may be aware of and we might not be aware of, it influences how we show up to our clients and how we make decisions clinically for these clients. Bias, stereotyping, prejudice, and clinical uncertainty are discussed as contributors into unequal treatment for those receiving care. Okay, so we've turned to some of the allied health professions. We've looked at their literature, and now we can look at some of the professionals that we work with closely here in behavior analysis. We're going to look at APA, that's the American Psychological Association. We're going to look at ASHA, the American Speech Language Hearing Association, and then the American Academy of Pediatrics. And what we've seen in these other professions is a really impactful implication and requirement on diversity, equity, inclusion, and cultural responsiveness. The APA has a task force on diversity. They have training requirements for psychologists, and then they have policy statements when you do a scope of their website, their training, and the literature. ASHA, the American Speech and Language Hearing Association, has a diversity task force. They have training requirements and they also have policies. And then the American Academy of Pediatrics, they also provide diversity task force. So that's really nice to see that there is a diversity task force across all of these organizations. They have training requirements for pediatricians, policy statements, and then guidelines to respecting diversity. I think this slide in and of itself for me is an area in which our field can grow and continue to develop. I know that this is starting to come about as a requirement, and I think that this is something we can dive into further. I also think that, you know, we can also take this as the field begins to adjust, and we can provide this within our organizations. You can have a diversity task force within your organization. You can spearhead that. You can really take the literature that's presented today, jump into it, and present it to your organizational leaders and indicate the need for such a force. The next few slides, we're going to talk about ASHA just because they're so closely aligned to us, and they have on their website really, really nice checklists that we as practitioners can walk away with. If nothing else, you can check these resources, go in there and say, okay, how can I bring this into my care today? So ASHA has a personal reflection checklist, a service delivery checklist. That was the one I think I loved the most because, again, I'm a practitioner who's going into homes, serving clients. The service delivery checklist is something I can administer to myself. And I can kind of circulate that with my treatment team to ensure that they're evaluating that. And then lastly, they have a policies and procedures checklist. So again, personal, that's for yourself. Service delivery, you might do that with yourself and your team of technicians. And then policies and procedures, that's at the leadership level if your organization is interested in applying this to the organization at large. What do they have in that personal reflection checklist? I'm going to just break down a little bit of this. The degree to which practitioner understands or practitioners understand how culture impacts the client's life, right? This is important for us as behavior analysts because we're oftentimes going into homes making decisions of social significance. So we need to understand parenting styles, extracurricular activities, and communication styles. They also have an evaluation of the degree to which practitioners understand and respect differences in norms and values. Another great one for us as we start to serve a wide range of individuals. If the practitioner holds any discriminatory views or engages in discriminatory practices, this is also evaluated in that checklist. A great one to administer on yourself, just to be aware of your own biases and your own experience as you are serving your clients. The service delivery checklist. This includes the frequency with which practitioners adhere to culturally responsive service delivery, considering norms and differences. It allows for different methods of communications. I know for the families that I serve, some of them really do enjoy parent training followed up by an email. So everything we might have discussed, I'll type up the notes and send it to them. Whereas some families very clearly say, hey, I just love to have a parent training session where we're communicating. I won't read the email. Don't even worry about writing that up. Every individual we serve is going to be very unique and different. Some of the families that I serve that have English as a second language, they prefer the email because they may have been lost in the translation during our discussions. If I am heavy on the jargons, that's also difficult for them. So breaking it down via a communication style that works for your family is super important and helps them follow through or adhere to some of your recommendations when you're not present. And then in this service delivery checklist, understanding how clients' backgrounds may be associated with diagnoses and how they impact speech, language, and hearing. Another great one for us to consider in our practice. And then a large component for the policies and procedures checklist, steps that an organization can take to ensure cultural competence or culturally responsive care are present. So some of these include employment, recruitment, policies regarding discrimination, inclusion of various backgrounds at the leadership level, and individualized feedback based on performance. So those are some recommendations. I love those sites. I think they've been super helpful to my own practice as I consider culture in behavior analytic practice. We've got two great papers that have been published in our own space in behavior analysis that allow for us to consider culture in our own practice. And these are nice tools because they are self-assessment tools, both of them that I'm going to present here. This one is by Leland and Stockwell, published in 2019, and this is a transgender and gender nonconforming self-assessment tool. This paper and this tool is primarily present to address behavior analysts' adherence to ethical guidelines, the arrangement of supportive and inclusive environments for supervision as well as for supervision of technicians with clients. It allows us to understand whether the behavior analyst engages in supportive behavior and refrains from engaging in non-supportive behavior for transgender and gender nonconforming clients, students, supervisees, and colleagues. The goal of this paper was to develop an LGBTQIA+ supportive environment in the workforce, in educational institutions and clinical settings. And they have questions reviewing the extent to which responders represent, support, and model inclusion and gender affirmation across these environments. So this one's a fantastic tool as our field really does move into these conversations and topics as we encounter some of the clients that might align with LGBTQIA communities. We want to be sure that we're aware of how to support them and aware of our own biases that might exist without our knowledge, so that some of that unconscious bias. It's also a great tool for your supervisees. It's a great publication. I suggest you read it. I need to go back and reread it to ensure that I am aware as I move ahead. And then this one, Gatzunis and Colleagues 2022. So this is a more recent publication. It's a culturally responsive supervision self-assessment tool. I love this one. Another great one for you to walk away with and take into your own practice. In this tool and in this paper, the authors talked about understanding how the cultural and racial backgrounds of the supervisor and supervisee may impact aspects of the supervision process. Another thing that we may not have considered in previous experience. I was certified over 16 years ago, and I received my training over 20 years ago. And one of the things that really has been an MO for me, and it's been there since the beginning, was an experience I had with a supervisor in, gosh, I would say 2001. The supervisor at the time was a white woman who was walking next to me as I was training a child to ride a bike, and I was working on pushing pedals. And I remember kind of being on the floor. Sometimes when we're teaching pedaling on a bike, we have to kind of be right there on the floor, pushing each pedal over and over. And this BCBA at the time looked down at me and said, I don't think this is the field for you. I'm not sure you're going to make it. I think that you're not understanding prompting and prompt fading. And for me, this first component of this self-assessment tool would have been really helpful for that interaction with that supervisor. Just as a minority woman, working as a technician, on my hands and knees, doing something really difficult with a child, and having a comment like that, it felt very out of place and inappropriate, and has really been a motivating factor for me to understand that even the comments that we make that maybe, she maybe didn't make that with any ill intent, but just being aware of comments like that and how that can be hurtful to a supervisee, a technician, really does impact the ability to thrive in that environment. So this is a great tool. The second component of this tool is understanding how the cultural and racial backgrounds of an individual receiving ABA services may impact aspects of their clinical care, something that we really do need to consider as well. And then looking at the behavior of the supervisor, both at the onset of the supervision process and throughout the delivery of supervision. So this is a nice tool for supervisors and supervisees to practice and participate in role play scenarios and open conversations to ensure they strengthen the responsive and inclusive practices for the clients and for their relationship as a supervisor and supervisee. All right, we have gotten through a lot of our topics here, so I'm going to shift us over to another quick Mentimeter. Let's give it a second to launch here. Again, menti.com, and the code is at the top. It is 704-9143. What specific steps have you taken to develop cultural humility in your practice, and how has this changed your approach to service delivery? Feel free to drop in. This is an open-ended response here if you've taken any, because I think it's important, especially for those of you who have taken training in culture. And what are some things you've walked away with? What are some practices that you've engaged in? And I know for myself, it's just to be more aware of biases, more aware of how I show up as a supervisor for those individuals receiving supervision from myself. This is great. So many of you have taken more training. That's fantastic. Open and aware of other differences, listening to clients carefully, adding in questions related to the cultural considerations and intake. I love that. I think that's one that I've seen a number of individuals start to participate in, is just taking that intake packet and making sure that they ask those questions, not when they're seeing cultural differences between themselves and their clients, but really for everyone, to make it equitable, right? To ensure that we're asking everyone if they need a translator, if they are aware of any cultural implications for care. All right, thank you. We've got a lot of respondents here. These are fantastic. Journal article reviews with the team. That's fun. All right. I love seeing everyone's responses. This is really fun, and thank you for participating. Okay, we've talked a little bit about the ethics code. We're going to revisit the ethics code. This is an ethics CEU, and I think it's important to ensure that we're aware of how culturally responsive care is impacted by our ethics code. There are 4 key components or 4 key principles within our ethics code for behavior analysts. And we want to ensure that when you read the code, and these conversations come up often, right? Is the code, like, is this, something that we have to have printed all the time on our desk? Or is this something that we should always be aware of? I think the spirit of the code is something that we as practitioners, technicians, registered behavior technicians, and everyone certified as a BCBA, BCABA, and a BCBA-D, we should embody and serve clients and supervisees and those that we work with the spirit of the code. And that is by benefiting others, treating others with dignity, compassion, and respect, behaving with integrity, and ensuring competence, right? Those are really important components of our ethics code. But what are some of the ethics codes that relate to culturally responsive care, diversity, and inclusion? 1.07 is cultural responsiveness and diversity. I'm not going to read all of it. It was in that very first slide. But what it indicates is that behavior analysts actively engage in professional development activities, very much like you're participating in today, to acquire knowledge and skills related to cultural responsiveness and diversity. Right. And in that, not only are we evaluating our own bias and abilities and competence, we're doing that for those that we train and supervise as well. 1.08, non-discrimination. Behavior analysts do not discriminate against others. They behave towards others in an equitable and inclusive manner. That's another one that's really important, right? We do not discriminate. And in doing so, if we even lean or inch towards discrimination, we might have something internally that might, an alarm that might sound off. We do everything we can to 1.10, become aware of our personal bias and challenge. Behavior analysts maintain awareness that their personal biases or challenges may interfere with the effectiveness of their professional work. So if we are aware, if some of those alarms go off, things that, when we become aware start to sound, we take the appropriate steps to resolve interference, ensuring that we continue to behave in a professional manner. So just a reminder of some of those ethics code as we dive into culture and supervision. This is a fun one. Feel free to drop into the webinar chat. How many of you have the privilege of supervision, right? Privilege of supervising someone who is accruing hours to become a behavior analyst, the next generation of individuals out there. We're going to explore the critical intersection. I think it's going to be a large majority of respondents here. We see some hand raises, but we're going to explore the critical intersection of cultural competency and supervision in behavior analysis, right? As BCBAs, it's our ability to provide effective supervision while being culturally aware and responsive, and understanding that that supervision directly impacts client outcomes, the development of those individuals that we oversee, and then our field's growth, which is very important. So some of the topics we're going to cover: diversity in the field of behavior analysis as it relates to supervision, cultural responsiveness as a component of supervision, and then rapport building in the supervision process, and then some of those barriers to effective supervision. We've talked about diversity a bunch today. I've talked about some literature that supports understanding diversity. Fong and colleagues in 2016 published another paper in regards to diversity and supervision. The Fong and Tanaka paper in 2013 was another paper on multiculturalism in behavior analytic practice. So again, some literature to consider, and at the end of the training, there will be kind of a reference list as well. What are some barriers to supervision? I shared my own personal experience. I did see some messages come through in the chat. Thank you for those. It was so long ago that I almost forgot about it, right? Some of these trainings bring some of those moments back to life, but those moments drive us to continue to strive to be better for our clients and the field. Some of the barriers we experience in supervision as they relate to diversity. Number one, diversity, if it's not acknowledged and supported, it can be a barrier to effective supervision. Very similar to my experience, if you're not aware of comments that might be made or the difference of your supervisee, it might impact your relationship with that individual. Collaboration and rapport building are key markers for developing a strong supervisory relationship. I love this one. I think I teach adjunct at National University, and I'm teaching supervision currently. And one of the biggest things I talk about is the requirement for rapport building in supervision. That supervision isn't just the signature on a contract, but it's a relationship with the individual whose hours you're overseeing and whose career you're building. So we know that differences should be acknowledged and communicated between supervisors and supervisees, and that it's the responsibility of the supervisor to manage the process, especially when there's a breakdown in communication. A good supervisory relationship involves bidirectional feedback between the supervisee to the supervisor and the supervisor to the supervisee, and then clear communication between both parties. So how does culture impact supervision? 1.05E, behavior analysts do not harass or demean supervisees. We know that's one of the codes that we adhere to. 1.05D, behavior analysts do not engage in discriminatory behavior against supervisees. And 1.05C, behavior analysts must be competent to supervise people who are different than they are. So we're talking about this competence. It's not that you have to demonstrate I've taken a number of CEUs on this different culture, but that you have become aware of your culture, your bias, your impact, and your own professional scope to ensure that you are able to provide supervision that is supportive to an individual aspiring to grow in this field. Individualization, this is a big one. Supervision styles for those accruing hours should be individualized very much like they should be for the clients that we serve. Reinforcers and preferences are idiosyncratic, right? We don't all love the same thing. We know that in group supervision, that is something that we can provide, but oftentimes the one-on-one allows for that idiosyncratic nature of feedback, reinforcement, and understanding the preferences of those that we serve, as well as their individual background. We should be developing the skills and reinforcing the skills of those that we supervise and train based on their individual reinforcers. So what are some great ways to evaluate reinforcers for adult learners? Again, fun one to drop into the chat. If you supervise or if you're seeking to supervise in the future, how would you identify what reinforces that staff member? I ask typically, right? Someone just said, I ask them. Absolutely. I also notice when providing feedback, if they respond well to that feedback. I've got some of my apprentices that I work with really do love, it's really interesting. Some I can ask, but some of them love when I send an email with an agenda and then literature to review prior to our meeting. Some of them just prefer to jump right in and have an open conversation. The agenda is a little overwhelming to them. So again, individualizing the performance feedback, the supervision style is really nice to say, I know what you enjoy. I know what kind of drives your motivation as a supervisee, and I want to ensure that I provide that in our relationship and in our experiences together. Oftentimes in supervision, we also have to engage in difficult conversations. We do have to do this with the families we serve as well, but this is related directly to supervision. Difficult conversations are a component that we as practitioners or behavioral analysts, we aren't trained in difficult conversations. I think it is a topic that is coming to the forefront of our field, but there aren't a lot of trainings that you can receive. And oftentimes, if you are trained, it's modeling from your current supervisor or previous supervisor. And it's, some of that behavior skills training if you're doing some role play. Differences often lead to difficult conversations. While perspectives, learning histories, and individuals may be different, these conversations do not need to be difficult or uncomfortable, even though the topic is difficult conversations. It is imperative that the supervisor engage in conversation regarding these topics to learn about and build rapport with the supervisees. Differences between professionals, educational, regional, and cultural should be celebrated and shared to increase rapport building and values alignment. So to avoid difficult conversations, right, we want to build rapport, and this can go for both supervision and relationships with the clients that we serve. And then it's also important as supervisors, those of us that provide supervision, that we open up the conversation to understand those that we serve, their background, their learning history, where they come from, what brought them into the field, to ensure that we can provide the best supervision experience possible. It is the responsibility of the supervisor to identify discomfort in their supervisees and seek to understand and support or improve that discomfort. We know that there are a number of terms for supervisor, but the term mentor plays a really key role in this experience. And there's a book, I actually have it on my floor. It is by Building and Sustaining Meaningful and Effective Relationships for the Supervisor and Mentor by LeBlanc and colleagues in 2020. Fantastic book. If you are moving into supervision, if you've been providing supervision, I'm going to reach over and grab it. I always recommend this book. It's wonderful. The chapters, the breakdown. There are some great things to work on with your supervisee. In addition, this book, the Sloan Publishing site has offered a large number of assets to supervisors. So you can go into their site. I know Shala is really wonderful in stating that she wants to make things as free as possible. So you can find PDFs to all of the chapters And you can also find some different self-assessment components. The book is, I'm going to put it up on my screen one more time. I apologize for not having a screenshot. Building and Sustaining Meaningful and Effective Relationships. And this is by Linda LeBlanc, Clara Sellers, and Shala Alai. Fantastic book. 3 wonderful women in our field who have just come together to talk about the relationship between the mentor and the mentee, and that's kind of what they call them throughout the book. And if you go to Sloan Publishing, you'll be able to find assets for that book on that website for free. Okay, and I can also drop that in. I know that it should be in the reference section as well. If not, I'll make sure I get that to MPG. So what are some ways to build rapport and supervision? Number 1, ask open-ended questions. Number 2, be patient and present, right? We learned from the survey that Taylor and colleagues published that sometimes behavior analysts aren't present. We are busy, we're behind the computer, multitasking and taking notes on parent interactions. Being present is very important, not only to those that we serve, it's also important to those that we supervise. Engage in active listening, and then demonstrate supportive body language and countenance. So all of the things that we want to do for our clients, we want to do for our supervisees as well. As leaders in this field and as individuals who have the responsibility of supervision, we engage in a number of components that are leadership responsibilities, right? We should evaluate our privilege, our opportunity, our access, benefits, and chance. And when we think about these in relation to supervision and culturally responsive care, privilege is the notion that some individuals have different and better chances and opportunities as a result of being in a particular group. And that's something that as we shift into bias evaluation, that's something that we should be aware of. Some of these privileges include gender, race, ethnicity, religion, wealth, sexual identity, and regional impacts of privilege. So as supervisors, we should evaluate the power difference between individuals, and then we should also review and demonstrate awareness of privilege and coming from a place of privilege. All right, I think this is my last mentee for the webinar. Okay, and we just talked about supervision. So join me at menti.com, 6704-9143. What modifications have you made to supervision practices to better support supervisees from diverse cultural backgrounds, if any? An open door policy, I love that. That's a great one. I know I ask a lot about just personal information for my apprentices, really getting to know them as individuals, where they come from, what brought them into the field, asking for feedback. That's another one that you see in the literature, that providing feedback to the supervisor as a supervisee sometimes is difficult. So sometimes asking for feedback, anonymous feedback is a great one. Researching their background and keeping an open dialogue. Ooh, the Trusted 10 activity, I would love to look into that. That's awesome. Open-ended scheduling, values, act, work, and education from the team. We also know that when we look at burnout, and some of the papers, Plantiview and colleagues talk about that one, that support is the biggest component that reduces burnout in behavior analysts and technicians, right? Making sure that we are supportive, not only when it comes to challenging behavior, because we know they need support in that capacity, but also just by listening and being present. All right, thank you so much for participating. This is fantastic. Okay, I'm going to pause for you all to take a moment to consider your own journey to becoming a behavior analyst and or supervisor. And then in taking that moment, think about the resources, the opportunities, or the supports that you had access to that others might not have had access to. So this is just a self-reflection moment. This is a big component that our field is moving into, reflexivity, being able to say, okay, I'm now a BCBA, if you are here in a BCBA. What are some privileges I had? I know, for example, going to, and I think someone indicated that in the chat, going to university, that is a privilege. Some of the individuals who might be technicians looking to pursue their career might not have access to going to a university. Having one nearby in proximity, having the funds to pay for graduate training, those are all resources. So something to think about. You don't have to share it, but just wanted you to note that and jot that down. As we're doing that, some things to consider, right? Did you have financial support for your education? Did you have support in graduate applications? Did you have access to supervision in person or via telehealth? Was your graduate degree taught in your first language? Did you pay for your own supervision? Did you have a mentor that shared your cultural background? Were you able to maintain a work-life balance? And did you have access to professional development opportunities? Those are all important things to consider as we consider our privileges and ways that we kind of got to be where we are today. Okay, we're going to move ahead. We have about 20 minutes left and so many things to talk about. So I'm going to jump to culturally responsive care as it relates to behavior analysis. This is the summation of what we've talked about here today. There are a number of papers that have been published recently in the field of behavior analysis that discuss the need for cultural awareness, humility, and responsive care. We're going to spend just a little bit of time reviewing some of the main highlights and contributions to our own field. And then if you're super ambitious, how you can extend that research, how you can continue it on within your organization in future publications, so on and so forth. Cultural responsiveness, it is viewing differences as strengths, creating a safe learning environment, and promoting justice and equity in society. And that was from Miller and colleagues in 2019. So they didn't just talk about cultural responsiveness as I'm aware of culture and I'm aware of differences, but I'm going to promote justice and equity in society at large. And we know that there's a large group of behavior analysts out there who are looking beyond the day-to-day clinical client services into actual socioeconomic, social background, social justice. It is a pedagogy that recognizes the importance of including the learner's cultural references in all aspects of learning, and then celebrating differences and embracing all that can be gained from an inclusive environment. So how can we incorporate cultural responsiveness? And I had a case example. I'm sorry, I skipped a slide. Just one fun case example here. I know I've got a couple, but because of the limited amount of time, I'm going to skip a couple. If you have access to the slides, you can practice those case examples with your team. Maria is a BCBA working with a Vietnamese family who prefers traditional medicine alongside ABA therapy. Rather than dismissing their cultural practices, what should Maria do to develop a collaborative relationship with the family? So I'm going to pause here, let you consider this one, and then I will share my screen with a couple of recommendations, things that I might do in my own clinical practice, not anything that we should all do. It's, again, my own experience, my own learning history, and how I might bring it to the table as Maria, as the BCBA here. So ways that I might incorporate cultural responsiveness for this family, I might learn about the family's cultural values. I might learn about traditional Vietnamese healing practices. And in that recommendation, I'm not saying I would suggest or abide by or follow these healing practices, as they may not be evidence-based, but I might listen open-endedly to allow that parent or that family to share their values in those Vietnamese healing practices. I would also collaborate and communicate with the client's caregivers to ensure cultural practices and values are being considered throughout. So when I'm reviewing the treatment plan, I might go over the goals and objectives and pause and say, hey, are these in alignment? Do you find these important to your child? Is there anywhere that we can modify or adjust if you don't agree? And really opening it up for dialogue and conversation. We talked about Skinner's definition of culture early on, right? Skinner defined culture as a collection of contingencies of reinforcement whereby individuals are born and exposed to throughout their lives. This is another definition, and it's one to think about. Sugai and colleagues in 2012 defined culture as a group behavior where individuals engage in verbal behavior reflecting shared group learning histories, which differentiate the group from other groups. That's something to think about when we work with families from diverse backgrounds, and allows for prediction with how individuals within the group will behave in specific conditions. So what does that mean into clinical practice? That there are a number of cultural contingencies, right, that are shaped and selected by the group in which one belongs. You can see some of these images here. Some cultures, direct eye contact is reinforced, and it's important. In others, avoiding eye contact with elders is reinforced. Some cultures reinforce individual achievement, and others reinforce group success. Some cultures value going to school and participating in going to a school setting, and others homeschool. Some cultures have a profound respect for elderly and interactions with elders, and some may do so in different capacities. So here's just a small little image to walk away with, considering cultural reinforcement history and how it might impact your learner in particular, your client, those that you serve. You can see we've got learning styles, we've got family dynamic, socioeconomic status, communication, social activities, and parenting styles. These are all components that are interrelated to the cultural reinforcement history of your client and their families, and then the group in which they participate in. Cultural awareness, it is the combination of self-awareness related to cultural diversity and bias. So that's the awareness that we have within our own culture and our own bias, including becoming aware when working with clients, understanding cultural identity, considering language in the assessment process, and developing skills to determine and evaluate how culture impacts behavior analytic treatment. So that's a lot to break down. Fong and colleagues wrote that in 2016. What they indicated were their components to cultural awareness: our own awareness of ourselves, our awareness of our clients, our awareness of our cultural identity and their cultural identity, an awareness of language and how it impacts assessment and treatment, and then how culture impacts the treatment that we're providing. So Belier and colleagues indicated that we need to recognize our own culture and see other cultures as equally valid to our own. Cultural humility, what is it? And I know Patricia Wright wrote a fantastic book in a fantastic publication, an article in 2019 titled Cultural Humility and Behavior Analytic Practice. It is a lifelong commitment to self-evaluation and critique to address power imbalances and develop mutually beneficial and non-paternalistic partnerships with communities. It's the ability to maintain a stance that is other-oriented in relation to aspects of cultural identity that are most important to that person. In behavior analysis, this is done by reviewing how other professionals adopt culturally humble practices. We did a lot of that today. We looked at allied health professions, we looked at some of their practices, and hopefully you're walking away with access to some of their checklists and tools. And then we can also do this by assessing the appropriateness of these practices during service delivery. Okay, here we go. We're jumping ahead. We're going to engage in another self-assessment moment. Think about a time when you made an assumption about a client's culture, learned something new from a family, and then when you think about that, did you adjust your approach and how you might show up and might impact clients differently? You don't need to share that. Go ahead and think about that for yourself. And we're going to jump into cultural competence. This is a set of behaviors, attitudes, and policies that align in a system, profession, or group to work effectively in cross-cultural situations. That's the National Center for Cultural Competence, right? They talk about being culturally competent. However, some of the literature in our field, Fong and Tanaka and Patricia Wright, indicate that we will never be culturally competent. We won't ever know everything about every culture, but we should be culturally humble. In this paper, or in the recommendation by the National Center of Cultural Competence, they indicate that it is achieved when an individual can integrate and transform knowledge about diverse individuals and groups into standards, policies, procedures, practices, and attitudes applied in cultural settings to enhance relationships and service delivery to improve outcomes. So that's a mouthful. What this indicates, and something that I think our field should walk away with, is ensuring that we begin to take what other fields have done in relation to culturally responsive care, cultural diversity, and start to have some checklists, a task force. And I know ABAI does have a special interest group, but it is definitely something to consider. We should learn to work with diverse clients and staff in an ever-changing landscape, right, that requires continuous learning and growth, knowing that we will never be masters of this. We should also be lifelong learners. Having that perspective supports the development of culturally responsive care skills. When it comes to the provision of services, something to walk away with is to maintain cultural awareness when working with clients, to foster a value for diversity, to provide culturally competent, sorry for that typo, culturally competent care, provide culturally responsive care to all clients, not just those that appear different from us, incorporate social validity measures with all clients and caregivers to incorporate feedback into treatment, allow clients and caregivers collaboration in the assessment and treatment goal selection. I'm going to pause here for that last code word. I know we've got about 10 minutes. I've got some more slides to get through, but I want to pause. That last code word for your CEU is support. All right, support. Okay, I'm going to turn our last 10 minutes into a topic. Again, if you see the slides, you're going to see just a couple that I had to skip due to time. I went a little bit heavy on slides, but I'm hopeful that this has been helpful to your clinical practice and your learning. We're going to talk about unconscious bias. I think ending here with some self-reflection at the very end as you sign off will be really important to your own practice and your awareness. Unconscious bias, it is defined as implicit social cognitions that influence understanding, actions, and decisions without conscious awareness, right? That's the biggest component. We are not always aware of our biases. It can affect clinical decision-making, treatment planning, and client interactions, and it is present in all individuals, regardless of profession, professional training, or conscious commitment to equality. So very similar to the survey that Bridget Taylor and colleagues published, many people who participate in webinars like this one on culturally responsive care are participating as a self-selected group. They are very interested in culturally responsive care and developing their skill set. However, all of us, no matter how hard we try to remain open-minded and how committed we are to equality, we do have unconscious bias in our repertoires. Unconscious bias is an implicit bias, which is automatic, normal, and a learned stereotype that is developed over time and is deeply ingrained. And that was from Crandallmeyer in 2020. What they talked about was unconscious or unintentional feelings or thoughts that exist outside of our own awareness. Why do we develop these biases? Alspach, 2018, said that it is a normal part of development for people, places, and others into stereotypes, for us to place others into stereotypes, because it helps us separate early on friends from adversaries during interactions. For me, this quote here was really impactful, because we may be very aware of our own bias, really committed to equality. However, we develop stereotypes as a normal part of our development when we place adversaries into groups versus those that might be friends. So we have to do the work to remove that bias from our repertoire. Through repeated personal experiences and cultural socialization and habituation, thoughts about others develop over time that are difficult to control and are often outside of conscious awareness. And that was from Burgess and colleagues in 2017. So these unconscious thoughts, they can lead to individual favoring or disliking something, someone, or groups of people in a way that may be considered unfair or create negative attitudes. It can exist towards a minority group, a social group, gender, race, ethnicity, religion, the LGBTQIA community, individuals with addiction, physical disability or ability, age, weight, and other characteristics. So these biases exist, and it is important for us to do the work. This image is the iceberg of bias. At the top, that's the conscious bias. Those are the ones that we're aware of, right? Maybe some cultural stereotypes that we're working to dismantle, some treatment beliefs about treatment that's required for clients that we serve, social preferences, and language preferences. Unconscious bias under the icebergs, things that we might not be aware of. These are our decision-making filters. Our cultural background, our personal experiences, our implicit associations, our professional training, the ones that we choose to attend, and then our cultural expectations. Those are all unconscious biases under the iceberg that we may not be aware of. And maybe today this training will kind of bring that up to the forefront for you and allow you to start to consider what your own biases are. But literature from the field, what can we look to? No matter how egalitarian of views, bias is pervasive among all healthcare professions. And that's from Jones 2022, and this is an evaluation of clinicians' biases. The delivery of treatment that is equitable and optimal can be limited by requirements of time, complexity of managing client relationships, and cases. So they talk about this often in other healthcare or allied health professions, that bias exists, and sometimes bias is exacerbated due to the fact of session notes, data collection, moving from client to client, requirements of administrative responsibilities on the practitioner. Clinicians' biases in allied health professions have been shown to be moderated by their own personal identities, so race and gender. Therefore, training and exposure to culturally responsive care is important to remove these biases and provide practitioners a way to support clients of different backgrounds. Got just a few minutes here. I'm going to wrap us up. The influence of bias. What is the impact of bias if it does exist? Unconscious bias influence patient-physician relationships, treatment decisions, and can impact patients with preferential treatment. Underlying attitudes and perceptions can contribute to unconscious bias and affect the care and treatment provided to patients. Bias influences decision-making for how we speak to others, how we interpret others' behaviors, the language we use to discuss clients, as well as the attitudes we might have towards clients. And then lastly, the language and ease we feel when speaking to clients and caregivers is impacted by bias. We may speak freely and openly with some clients while spending less time speaking to others. And those are just some things to consider. So we're going to talk about that impact, and then I'm going to wrap us up with a couple of tools that you can walk away with for implicit bias training. Here is how unconscious bias impacts behavior analytic services, right? Our assessment interpretations, we may make decisions based on bias versus individual client need. It may impact service delivery. Equitable and optimal treatment is impacted by bias. We found that in the previous or other allied health profession literature. Time requirements and complexity of managing client relationships and bias. It also impacts treatment recommendations. Treatment recommendations might not consider cultural variables, individualized client needs, or caregiver input. It impacts rapport and therapeutic relationships. Bias affects how we develop rapport, listen to our clients, and provide caregiver consultation. And then it creates barriers to effective service delivery. Bias affects our underlying attitudes and perceptions of others that can contribute to the care that we provide. So what do we want to do? We want to provide a culturally safe environment. Cultural safety is providing effective and compassionate care, promoting diversity and equity in treatment by offering client-centered support. We want to work towards limiting inequities in access to healthcare, especially in behavior analytic practice, by bringing awareness to discrimination and biases that contribute to any disparities. And then in providing cultural safety, we should not focus only on mastering cultural awareness, but also educating our staff, our teams, other practitioners on unconscious bias and cross-cultural issues versus characteristics of a culture. So more broad evaluation of bias versus I'm going to learn this particular culture. Now, if you're serving a family with a particular cultural background, it will be important for you to evaluate and learn about that family so you can provide effective care. Two great tools to evaluate bias for behavior analysts. We want to ensure as behavior analysts that we provide cultural safety to clients to mitigate the impacts of the biases that we might know about and some that might be unconscious bias. This means providing effective and caring services for diverse populations that promotes equity while breaking down barriers and offering additional supports that are individualized to the client. So there are two tools that you can look into. Both are easily found if you do a Google search or a lit review. The implicit association test, that's an IAT, and that was developed by Greenwald and colleagues in 1998. It is a test that evaluates automatic associations between concepts and categories, as well as perceptions of individuals. It will provide just some bias association so that you can become aware of your own bias. I've had supervisees complete it. I've done it myself as well. The Implicit Relational Assessment Procedure, the IRAP, was developed by Barnes-Holmes in 2006. And this was developed as a method of capturing arbitrarily applicable relational responding, or the strength in patterns of verbal responding, and it's utilized to study implicit attitudes and beliefs. I do like the Implicit Relational Assessment Procedure. It is one that I've administered a number of times, and it allows me to inform my bias and if it's shifted over time, and my supervisees as well, so we can have an open discussion. Okay. We're wrapping up. Ways to evaluate bias. As behavior analyst supervisors, we should engage in role-play scenarios, evaluating supervisee facial expressions, communication styles, tone of voice, and body language when working with diverse populations. We should engage in reflexivity, right? We should evaluate our own personal bias, beliefs, and assumptions, while also remaining aware of individual unconscious bias during our interactions with others. I know that if I feel a red flag pop up, I need to go back and look at that red flag and understand why that might have popped up for me in my experience with others. And then as supervisors, we should facilitate awareness, acceptance, and management of unconscious bias, utilizing role playing, observations, and discussion on how unconscious bias during training can be beneficial. I'm going to go ahead and pause. There are references here. And then pop it to our Q&A. You can feel free to drop any questions in the chats. And I know I will receive an email if you drop any in there and we don't get to answer them in time.
Unfortunately, I don't think we have any extra time to spend on questions, but yes, as Nissa said, if you do have any of your questions, just go ahead and put them in the Q&A so we can make sure that they are seen. All of these questions will be sent to Nissa, and she will have the opportunity to answer a couple of them, and we'll be posting them on our social media platforms within the next week or two. This does conclude the end of our presentation. I wanted to thank you so much, Nissa, for joining us today and presenting a much needed topic as we are growing in the field. And thank you everyone else for joining us today. I will stay on for a few extra minutes to support with any questions that you might have regarding like CEUs or anything as far as non-content related. Again, if you have any questions regarding content, I will send those on to Nissa. Nissa, you do not have to stay on if you do not want to, but you are more than welcome to if you like.
All right. Thank you all for joining. This was fun, and I look forward to the next time.
All right, thanks.